Okay, good morning. I guess we're going to get started. Thank you, everyone, for being here today. Before I introduce the speaker, I wanted to remind everyone that you can get CME credit by dialing 312-957-8301. And the text number is 56774 is in the chat. You can see these numbers. And if there are any questions during the whole presentation, we will be collecting questions. The questions can be emailed to cancer@northwestern.edu, and then they will come to me and I will ask the speaker. So I'm really pleased to introduce our speaker today, who beyond being an exceptional virologist, is also a longtime collaborator of mine, a good friend. Eleanor was born in London, and she grew up in the UK, and she completed her undergraduate degree at the University of Manchester. Then she was at the King's College in London for graduate studies, where she got her first degree in virology. And then she moved to the University of Toronto, working on cell biology and virology, and where she stayed during her whole career. Now, Eleanor has made some major contributions in the interferon field in understanding how interferons and cytokines work. She has gotten numerous awards and honors. She's an elected fellow of the American Academy of Microbiology. She has gotten the Milstein Award from the Cytokine Society. She has been elected a fellow of the African Academy of Sciences. She holds a Canada Research Chair, and she has too many distinctions to note. Now, beyond her work in the lab, she has been also driving some international efforts during viral pandemics. So when the Sars outbreak happened in Toronto, she coordinated and they developed a clinical trial of interferons during the Sars outbreak. She also participated, she also she has had extensive activity in Africa, and she also developed a clinical trial on Ebola in Guinea in 2017 when the Ebola outbreak was. And plus, she was involved in treatments for the Middle East respiratory syndrome, MERS, which was the precursor to what we have today at COVID-19. And she has been working with the World Health Organization. Now, when during the coronavirus pandemic, Eleanor got involved again, and you will hear about the trial that was developed in Wuhan, China. So I want to thank Eleanor for joining us, and we can get started.
Thank you very much, Leon. So what I'm going to do now is share my screen and hopefully go ahead with my presentation. So what I'm going to do this morning, I hope, in the next little while, is convince you that when there are these global virus outbreaks, we should, for severe acute infections, we should immediately prioritize interferon treatment. So just to remind everybody that global pandemics are not unusual. And in this map of the globe, what I've done is I've highlighted a number of virus outbreaks, that you can see span the whole globe. And some of these are recurring on an annual basis. And some are for newly emerging or re-emerging viruses. So for example, we're all acutely aware that with HIV, for which there is no vaccine to date, there have been over 40 million people who've been infected, and every year there are more and more people infected. West Nile virus, which started, as you can probably tell from its name, many years ago in Uganda, has now spread around the globe in both the southern and northern hemispheres. Ebola virus that Dr. Platanius just mentioned We first learned of it in 1976. Then there was the 2014-16 outbreak in West Africa, and most recently a continuing outbreak in the Democratic Republic of Congo. And what we should again be aware of is that for Ebola virus, at the time of these outbreaks, there were no antivirals and no vaccines. For Zika virus, no antivirals, no vaccines. West Nile virus, no antivirals, no vaccines. I can go on, but the point I wish to make is that every time there is a new outbreak, we're playing catch up to develop a new vaccine. And I'll touch on that a little later when we talk about COVID-19 and the vaccine development there. But what I do want to draw your attention to in this particular slide, that coronaviruses are not new to us. So as Leon mentioned, during the 2002-2003 outbreak that started in southern China, from Hong Kong and then traveled around the globe and actually arrived in Canada, we saw again a relatively severe coronavirus with no vaccine and no antivirals. Subsequent to that, there was the Middle Eastern Respiratory Syndrome coronavirus in 2012, which spread to over 27 countries, no vaccine, no antiviral. And I can go on and on. But for SARS coronavirus in 2002, there were globally 774 deaths, MERS coronavirus 858, and we're going to talk about the SARS coronavirus 2 a little later. So what do we know about our immune response to virus infections? Well, the first line of defense against any and all virus infections is our innate immune response. And indeed, the first 24 hours or the first days are critical and determine the outcome. A good, robust immune response leads to a good outcome. And what I hope to convince you is this is all dependent on a type 1 interferon response. So this is just a scheme to remind us all that we have a very effective immune surveillance system to detect virus infections. These are pattern recognition receptors, which identify pattern-associated molecular patterns or DAMPs, the DNA, the genetic material, damage-associated molecular patterns. And these recognition receptors for the viral presence are either on the cell surface. I've shown you here a number of toll-like receptors and also dectin and DC sign in endosomal compartments, toll 3, 7, 8, and 9. They may be cytoplasmic, such as the NOD receptors, RIG-I, MDA5. But what I hope this scheme illustrates is regardless of the receptor and regardless of which cell type those receptors are on, and regardless of the virus that activates those receptors, DNA, RNA, enveloped or not, the end point of all of this, as you can see in the lower section of that slide, is the activation of an interferon response. So receptor recognition of a virus leads always to the activation of an interferon response. And why is that? That's because interferons are very pleiotropic in the context of their biological activity. Notably, because viruses can infect any cell type, whether it's a respiratory virus, an enteric virus, a cardiotropic virus, a hepatotropic virus, these receptors for interferon that I show you in the top of this scheme have to be on pretty much any cell, because any cell can be infected by a virus. And what we can see here, and this is work that I've done over many years in collaboration, the lead here was Leon and his group, what we've been able to show that interferon activation of that cell surface receptor leads to an incredible cascade of signaling pathways that you can see here. And the key point here is that these signaling pathways lead to histone modification and transcriptional activation of a number of genes that I show you in the right-hand lower portion. And certainly the ones I've identified here are absolutely known to be involved in direct antiviral inhibition of viral replication. At the same time, we know that because viruses replicate very quickly, it's important that that transcriptional activation is translated into protein products. So interferons also very effectively through the mTOR pathway regulate mRNA translation. So there are a multitude of signaling events that lead to the direct antiviral activity of interferons. These interferon-inducible genes that I've identified are associated with inhibiting various stages of the virus replicative cycle, whether that be inhibiting the entry of virus into cells, uncoating of envelope viruses, degrading of the viral genomic material, preventing protein assembly to form the virion, or indeed to prevent egress of the virus. So interferons are able to activate multiple signaling pathways to block a virus replicative cycle at many different stages. At the same time, which is often overlooked, interferons are very effective in activating an immune response to clear virus. So interferons are involved in the proliferation of hematopoietic stem cells that would lead to the production of a number of immune cell types, dendritic cells, monocytes, macrophages, natural killer cells, B cells, T cells, and their subsequent activation. So for example, interferons will activate natural killer cells to become more effective killers, will polarize CD4 positive T cells to become T helper 1 cells, will activate CD8 positive T cells to become cytotoxic. And what we're learning with, certainly with coronaviruses, is that CD8 positive T cell response is probably very important for clearance of virus. Indeed, interferons will also activate B cells to become plasma secreting cells, antibody producing cells. So the point of this particular scheme is to remind us that in addition to the direct antiviral activity of interferons, type 1 interferons, interferons alpha and beta, they are also very effective at activating an immune response to clear virus at the site of infection. So now let's move ahead and let me illustrate why, because these interferons are so pleiotropic, I believe they have a role in acute virus infections. So during the 2002-2003 outbreak of SARS, we learned that there were over 8,000 individuals worldwide that became infected. And as I mentioned earlier, a total of 774 deaths. And in Canada, we had 251 infections and 43 deaths. And to remind you that at the time of that outbreak, there was no vaccine and no antivirals. And what we've subsequently learned is that the vaccine that was subsequently developed for this SARS coronavirus had to be withdrawn because it appeared to exacerbate and result in very severe coronavirus infections. What we've also learned over many decades is that because interferons are so effective at blocking multiple stages of the viral replicative cycle and also mustering an immune response to a virus infection, and that's regardless of the virus, what we've learned is that viruses have co-evolved to very specifically block an interferon response. And the SARS coronavirus 1 is no exception to the rule. It encodes in its genome 4 factors that I've identified on this slide. The non-structural protein 1, non-structural protein 3, open reading frame 6, and the M protein, which very specifically are involved in blocking interferon and interferon response. At the time of the outbreak, what we did was looked at the potential for a novel synthetic interferon alpha con1, to limit virus replication. And what I show you in this slide is the effectiveness in an in vitro assay of two potential drugs that were looked at that time by my group. That's ribavirin, which was the standard of care around the globe during the SARS outbreak. And as I said, this novel synthetic interferon alpha-COM1. And what I hope you can see in this particular slide, that with increasing concentrations of ribavirin, up to 2,000 micrograms per mil, it was completely ineffective at inhibiting the replication of this SARS coronavirus. But by contrast, interferon alpha-COM1, up to doses of a maximum of 5,000 international units, completely inhibited virus replication. This, despite the fact, as I mentioned, the virus encodes in its genome factors that will block an interferon response. So it's possible to override those inhibitory effects by treating with interferon. As a consequence of that, we moved ahead in Toronto with a clinical study to look at the potential for interferon to be effective at limiting virus replication and having therapeutic benefit. And this was quite an undertaking at that time, because we had to get compassionate release for drug use, and had to very rapidly get everything in place in one particular hospital. But what I show you here are a series of chest x-rays for 3 different patients. So patients were consented to receive interferon alpha-COM1. This is this novel synthetic interferon alpha, which, as it turns out, over the years we've been able to demonstrate has a very high affinity for the interferon receptor, and is, in fact, as a consequence of that high affinity, has the highest potency compared with other interferon alphas. So patients were consented, and they received daily subcutaneous doses of interferon alpha-COM1, 15 micrograms. And in the upper panel, I show you a series of serial x-rays from day 9 symptom onset out to day 18 of a patient who did not receive interferon, only corticosteroids. That was the standard anti-inflammatory that was used at that time. And you can see that the lungs become progressively occluded as you go from day 9 through to day 18. In the lower 2 serial chest x-rays, these were patients who received interferon alpha-COM1, and I hope it's fairly obvious to you that by day 14, and certainly by day 14, in both series of chest x-rays, the consolidation, the opacity reduced, and the lungs cleared. So daily interferon treatment improved lung abnormalities. And indeed, when we looked from the worst chest x-rays to time to 50% resolution, this plot identifies that for the interferon treated patients, their time to resolution was 4 days on average versus 11.5 days for those that did not receive interferon. If we looked at other measures of this particular disease, let me draw your attention to the right-hand panel first. Obviously, because this is a respiratory infection, oxygen saturation is a good measure of lung pathology. And what you can see here in the open circles, in that plot, those patients who received corticosteroids, their oxygen sats dipped. And indeed, many of these went on to require nasal prongs for oxygen supplementation, and some went to the ICU. By contrast, those patients who received interferon alpha-COM1, that's the upper plot, the closed circles, their oxygen sats remained above 93% and did not require any oxygen supplementation at all. I also show you in the left-hand plot temperature, body temperature for those patients, and once again you can see that there seemed to be less, these patients all hovered around, whether they were treated with interferon or not, they all really hovered around normal body temperature. Fluctuations were minimal. When we looked at a series of other measures for these patients. And really what I want to do is draw your attention to the lower right-hand panel F to focus on creatine kinase. So throughout the course of this outbreak, we learned that spikes in creatine kinase were indicative of lung parenchymal disease, the severity of that lung parenchymal disease. And as you can see in this particular plot, by contrast to those patients who only received corticosteroids, those who received interferon never had a spike in creatine kinase. So our data suggested that indeed interferon treatment of these patients appeared to have therapeutic benefit. And at that particular time, I was invited to Geneva by the WHO, asked to share our protocol, and a number of jurisdictions subsequently have adopted it. I should also point out, because this is a common concern and very often the reason why there is quite a large hesitancy to use interferon, we saw no evidence of a cytokine storm in any of the patients who received interferon. And indeed, our data have been published in different journals on this particular clinical study, and the evidence for the absence of a cytokine storm, I think, is very clear. So interferons did not in any way exacerbate disease or induce a cytokine storm. And in fact, when we looked at a number of patients, we collected their peripheral blood mononuclear cells and did some gene expression analysis. What this particular plot shows you, patient 1 is one that received corticosteroids only. Patients 2 and 3, we looked at their gene expression following interferon treatment and its days relative to symptom onset. What I think you can see is that there is indeed a change in gene expression associated with interferon treatment, and many of those genes are indeed associated with an interferon response, antiviral response, defensins, and so on, defensin A1, defensin A4. So to reiterate, at that time, we were able to demonstrate in an exploratory clinical study that treatment with an interferon alpha seemed to have therapeutic benefit. So now we're looking at a different coronavirus, SARS coronavirus 2, and to date we know there are, as of this morning, there were 3,940,830 cases around the globe and a total recorded 271,497 deaths. So by contrast, the numbers involved with this particular pandemic vastly outnumber what we saw with SARS coronavirus 1. Like SARS coronavirus 1, we know that type 1 and type 2 pneumocytes and alveolar macrophages are infected by this virus. And just to draw your attention to the fact that whereas with SARS coronavirus, we suspect that the fatality rate was 10%. Right now, we are guesstimating, based on the number of confirmed cases and deaths, and that's the limitations here are on the testing rate, that the fatality rate varies anything from 2 to 7%. But what I want to point out here is that the fatality rate is less than for SARS coronavirus 1. What other distinctions can I draw your attention to? So this is a very recent publication in Clinical Infectious Diseases by Chu and colleagues. And if I draw your attention to the upper plot, what this shows you is that for the blue plot, this is SARS coronavirus 1, and it looks at infectivity rate over 48 hours. And the orange plot is SARS coronavirus 2. And what you can see from this particular plot is that SARS coronavirus 2 has a replication doubling time which far outstrips that of SARS coronavirus 1. The multiplicity infection is much faster with SARS coronavirus 2 than SARS coronavirus 1. As I mentioned to you earlier, coronaviruses, in common with all viruses, encode in their genomes factors that will block interferon production and an interferon response. And in the lower three panels, I show you the gene expression, the ability of SARS coronavirus 1 and SARS coronavirus 2 to inhibit an interferon response. So if you look at the blue plots first and just focus on interferon alpha and interferon beta, you can see that SARS coronavirus certainly limits an interferon response, but for 24 and 48 hours, there is some level of interferon alpha and interferon beta production. By contrast, if you look at SARS coronavirus 2 and its ability to block interferon production, you can see that the levels at 24 and 48 hours for interferon alpha and interferon beta are significantly less than the inhibition that is what is inhibited, but still able to occur for SARS coronavirus 1. So not only does this particular virus replicate faster than SARS coronavirus 1, but also it is able to inhibit an interferon response to a greater extent. So what I want to show you now is some of the similarities between the two virus infections. And I'm aware of the fact that you've had presentations, I believe, from others on COVID-19. But what I show you here is from our hospital in Toronto, University Health Network. And this image was provided by a colleague, Dr. Neugen. And this is of a 68-year-old woman with fever, worsening shortness of breath, and her RT-PCR swab was positive 3 days prior to this chest X-ray. And what you can see is that the peripheral airspace consolidation is obvious in both the upper and lower lobes. So this is again an infection which affects both the upper respiratory tract and the lower respiratory tract, and the lungs become quite consolidated. So armed with the information that we had from our study in Toronto in 2002, 2003, and with some in vitro knowledge that we learned of and had from the MERS, Middle Eastern Respiratory Syndrome outbreak in 2012 and beyond, we decided to undertake an exploratory study to look at the potential therapeutic benefit of interferon treatment during the early stages of the outbreak in Union Hospital in Wuhan in China. So for this was, I want to point out, an exploratory study, not a randomized controlled trial. And this was a consequence primarily because we were right in the thick of the outbreak at that point. At that time, my colleague, who's the director of the CDC in China, was certainly aware of our JAMA publication and our interactions with the WHO during SARS. And there was an edict from the Chinese government that they, at that time, around about the middle of January, recommended interferon treatment for patients with COVID-19. So they had also recommended broad-spectrum antiviral Arbidol, which was widely used. It was available across the counter, no script, so many individuals were treated with Arbidol. So what we did is we undertook a study with 77 confirmed COVID-19 cases at Union Hospital between the time period January 11th to February the 12th. And patients, at the discretion of the attending physician, received either nebulized interferon alpha-2b, 5 million units twice daily. And this nebulized interferon, how this was delivered was essentially the soluble interferon alpha-2b was introduced into a medicine cup, nebulized, and then delivered as an aerosol to the patients via a mask. Patients were also received, others received Arbidol. These were tablets, 200 milligrams 3 times a day. And then there were others who received a combination of interferon plus Arbidol. For all the patients, they were serially examined for virus using throat swab PCRs. They had CT scans, body temperature, oxygen saturation was measured over their time in hospital, and blood biochemistry, cell counts, and cytokines again were monitored throughout the time that they were in hospital. So what I want to draw to your attention is that all the cases that were involved in this study were what we consider moderate COVID-19 cases, because no patient exhibited signs or symptoms of end organ dysfunction, and no patient developed respiratory distress that required any form of oxygen supplementation, any prolonged form of oxygen supplementation or intubation. What I show you here is 2 plots where we're looking at temperature and oxygen sats for the 3 different groups: Arbidol alone, Arbidol plus interferon, and interferon alone. And I think you can see quite clearly that certainly for temperature, they all fluctuated within normal range, all the patients in those 3 groups, and the same with their oxygen saturations. As I mentioned earlier, there was no requirement for oxygen supplementation. So no distinction among the 3 different treatment groups. Indeed, when we looked at a number of other parameters, and this is quite a busy slide, so what I really want to draw your attention to is that in this case, because patients received interferon alone or interferon plus Arbidol, for clarity and because we saw essentially no distinctions, we've combined the interferon alone plus the interferon plus Arbidol groups as an interferon treatment group and compared that with the Arbidol alone treatment group. And I think you can see from these plots that all these parameters that were measured essentially fell within or fluctuated within normal range, and there were no distinctions amongst the patients in the context of their treatments. Likewise, when we looked at a number of cytokine levels and procalcitonin, we saw that here I've broken it out into the 3 groups, again, because of this concern of cytokine storms with interferon treatment. Again, I think it's fairly evident that for IL-2, IL-4, IL-10, TNF-alpha, interferon gamma, and as I said, procalcitonin, these treatments essentially showed no difference in terms of the levels of circulating cytokines, and they all fluctuated, again, within normal range. We also looked at a number of cell populations, and again, I've broken them out here in the 3 different groups. And really, once again, we saw no dramatic differences among the individuals, regardless of their treatment, and everything fell within, I would argue, fluctuated within normal range, with the exception perhaps of platelet counts, which is in the 3rd row down to the far right, where you can see that there was a transient increase in platelets between the period of 5 to 30 days. But again, no distinction amongst the 3 treatment groups. However, we did see differences among the treatment groups in the context of viral clearance from the upper respiratory tract. So on the left-hand panel, I've broken this out for the 3 different treatment groups, and in the right-hand panel, again, combining those patients that received interferon, whether alone or in combination with Arbidol, and the Arbidol alone treatment group. And essentially what these data highlight is that interferon treatment accelerated viral clearance from the upper respiratory tract. This was a significant difference, and indeed it was an average of 7 days faster to clear virus from the respiratory tract for those patients who received interferon. And notably, comorbidities, age, and sex, which certainly influence disease severity, they did not negate the effects of interferon treatment that still remained significant. And the 0.002 is the p-value when the data are adjusted for comorbidities, sex, and age. Another distinction that we saw from interferon treatment was that interferon treatment reduced those biomarkers in the blood of inflammation, mainly C-reactive protein and IL-6. And IL-6, a pro-inflammatory cytokine, has been associated with the severe acute respiratory distress syndrome. So high levels are associated with ARDS. And what you can see from the left-hand panel, and I draw your attention to the fact that this is a log scale on the y-axis, there is a significant difference in levels of circulating IL-6 between those patients who received Arbidol and those who received interferon, whether alone or in combination. Those who received interferon, essentially their levels fluctuated around a normal range, just subtly elevated, whereas those that received Arbidol only had a significant spike in their circulating IL-6 levels. And the significance of the differences I've shown you here is in the p-value and the left-hand side plot. If you look at C-reactive protein, once again, there is a difference between those patients who received interferon, whether alone or in combination, or those that received Arbidol. Once again, when we adjusted for comorbidities, sex, and age, the interferon treatment effects remain significant, and the p-values I show you there are those that are adjusted for that. What I'm showing you here now is a series of CT scans for various patients who received the treatments in this particular study, and we haven't had, to date, we're working through scoring these CT scans, and there are a large number, but we've had to do that subsequent to our other analysis. And really the reason why I'm showing you this is because the resolution of lung abnormalities sometimes coincided with the time of viral clearance, and sometimes it took much longer, depending on the severity of disease, obviously. These CT scans were scored to a maximum of 20, where 20 would be the most severe. So for each of the upper and lower lobes of each of the lungs, the maximum score would be 5. And what you can see, for example, in the lower right-hand panel, is this is a patient who received, a female, 51 years old, who received interferon with Arbidol. She became PCR negative around about day 12, and that coincided with a very low CT score. By contrast, you can see in the upper right-hand panel a male, 32 years old, who became PCR negative on day 38. And you can see from the CT scan that the score on day 14 was 18, and you can see very clearly there the consolidated lungs and the severity of this particular, in this particular CT scan. On the left-hand upper panel, this was a female who received interferon, 30 years old. She cleared her virus on day 9, and this CT scan on day 14 still shows ground glass opacities. And the lower left-hand is an Arbidol-only treated patient, 68 years, PCR negative, out to day 24. And the CT scan on day 18 shows a score of 7. So viral clearance and time to resolution of lung abnormalities, we should take this into context. That's, rapid clearance of virus from our preliminary data suggests that the subsequent lung abnormalities were less severe but we remain to do all these studies in-depth analysis. So in summary, with all the limitations of this exploratory study, it was a small cohort, it was non-randomized, the treatment arms were an unequal size. Having taken all this into account and have it to the best of our abilities, tried to address this in our statistical analysis, I think it's fair to say that our data suggests that interferon treatment absolutely accelerated viral clearance, and interferon treatment reduced IL-6 and CRP levels. Most recently, there is a publication that has come out, a peer-reviewed publication that has shown that arbitol treatment appears to be ineffective in the context of clearing virus in COVID-19 cases. So this reinforces our data that we have a good comparator here with arbitol. Even when we adjusted for age, comorbidities, and sex, this did not negate the effects of interferon. And when I talk about sex, I'm talking about male versus female only, because we did not have data on pre versus post-menopause. We did not have data on whether these females were on contraceptives and on what stage of their menstrual cycle, which would all have an impact on their immune response. And certainly we would argue that these findings are the basis for randomized control trials, which I'm involved in now, looking at the therapeutic benefits of interferon treatment compared to placebo in a number of jurisdictions around the globe. So what I'd like to do is acknowledge those of my colleagues who I worked with for both the SARS coronavirus study in Toronto and more recently my colleagues in China and around the globe who worked with me for this SARS coronavirus 2 COVID-19 study. And just remind you to email your questions to cancer@northwestern.edu. Thank you.
Thank you, Eleanor, for a great presentation. We have questions coming, but let me ask, I want to start and ask the first question. So it clearly, because there was the arbitol arm here in your studies, it looks like interferon did have clearly activity. And the other antivirals that we have, remdesivir, okay, it shows some activity also, but nothing impressive at all. I mean, it's at least in severe patients. Then the other drugs, hydroxychloroquine, the data now are completely negative, and I think that drug will drop completely off. It's almost dangerous to use it. So the question is, do you think it will be warranted to have a trial combining interferon with remdesivir? And what do you think?
Absolutely. I think we've seen with, very difficult to treat viruses that combination treatments are absolutely the way to go. So I would like to undertake a trial with interferon plus remdesivir, and perhaps even post viral clearance, or once viral clearance is fairly well established in those patients, look at the potential for an anti-IL-6 as a subsequent treatment. Our data would suggest that the antiviral effect has a direct functional connection with the inflammatory response. So maybe that inflammatory response in the lungs would be dramatically reduced as a consequence of interferon treatment. That's what our CT data, what we're going through now to see if that's the case. But I think you need an RCT, and in answer to your question, absolutely, I'd like to look at combination treatments.
And I think that was quite impressive, because I think the fear with interferon was the inflammatory response. And that's the pushback of people say, why use interferon? You can exaggerate the inflammatory response, and it looks the opposite. Here is a question from someone. Why did you list the fatality rate for SARS-CoV-2 as 2 to 7% if the number of infected individuals is likely much higher than the confirmed cases? Many virologists predict that the fatality rate will be likely in the range of 0.3, 0.5%. What is your view?
So, you're absolutely right, but I'm not a prophet and I can't project, and I can only work with the data that we've been given so far. So in countries like Iceland, where they do 100% testing, we can absolutely say what the fatality rate is. What we also know is that this virus is mutating. So what it was in Wuhan in terms of fatality rate, I don't think we'll ever know. But I know in Canada, we're not 100% testing, so I don't know. And there are vulnerable populations where the fatality rate is much higher. So you're absolutely right. And how we ever tease this out, do we do this based on comorbidities? Do we do it based on age? Do we do it based on sex? Do we do it based on extent of testing? You know, you answer that question. But yes, the point is it's a lower fatality rate than the first SARS coronavirus outbreak.
Okay. Another question is that just came is, are there ways to administer interferon other than nebulizer for patients with respiratory distress?
Yeah, absolutely. So that the trial we're undertaking in Australia is going to look at sub-Q, and there's another trial that's going to look with inhaled. So we're going to have that information. The advantage of an inhaled or a nebulized interferon is that could actually, the devices that we're looking at could actually be used at home, whereas sub-Q is not easy to do. So they're early on with a mild disease, a nebulized interferon, I think makes sense, and maybe even prophylaxis for public health, for healthcare workers. But yes, sub-Q is absolutely a route to go. That's what we used in the SARS coronavirus 1 trial. We used sub-Q injection.
Yeah. So here's another question I have actually. The SARS coronavirus 1, the vaccine could not be developed because people were getting sicker with the vaccine. Correct. So that's something worrisome, obviously, about this virus. And I was wondering what you think. And I also wanted to ask you is if there were efforts with SARS coronavirus 1 to develop an antigen test. Was that, I assume there is nothing like this because people talk now about COVID-19, about developing an antigen test. Is that, what do you think about these two things?
So in the context of the vaccine, first of all, I've been in contact over a number of days, weeks with various folks who are working in Canada on vaccine development, and also those who are collecting plasma from patients and looking at their antibody titers. And what is quite, I would say, alarming is that certainly from the patients that have been looked at so far, their antibody titers are very low. Zika was one of the few virus infections where antibody titers were pretty low. It appears that with this SARS coronavirus 2, the antibody titers are even lower. There are some patients who develop neutralizing antibodies. Whether this will be effective in clearing virus is a big question mark. I alluded to the fact that the CD8 response might be more critical. So will it be possible to develop a vaccine that will be effective is a big question mark. And many different approaches are being looked at, whether it's a T-cell vaccine, or whatever. So I'm hesitant to say that we should be waiting for a vaccine. I think antivirals is the route to go. Your question about antigen testing, there are so many different strategies ongoing, whether it's antigen testing, antibody testing, PCR, The reality is that if we're taking throat swabs or nasal swabs, it's an awful way to get a reliable positive or negative. We saw this in Wuhan. Our strategy was patients could only be considered PCR negative if we had 2 swabs, minimally 24 hours day apart, that were negative. We got patients who were negative, then became positive, then became negative. So that the technique for sampling is not great. So maybe a blood test is a more accurate way to go. But how widely that could then be used is a big question mark.
Okay. Here is another question that just came. There are dramatic differences in clinical course, even among apparently healthy young patients when infected with the virus. Are there differences in interferon responses or other biological differences to account for this?
don't know is the answer. I mean, this virus doesn't just affect the lungs. We know now that it's able to affect different organs. And that's what the concern is. That young people are having strokes, young people are having renal failure, kidney, other organ dysfunctions. Whether the interferon response modulates that, the answer is I don't know. And the numbers of patients we had in our clinical study would not be sufficient for me to be able to evaluate that, hence the RCT, but a very good point.
Yeah, and regarding the timing of treatment for interferon, if someone, what do you think would be the appropriate time?
You've got to treat early. We have a window of opportunity where you need to eliminate virus. Beyond that, reducing the virus, I showed you some of the CT data. Virus infection leads to the subsequent sequelae. You don't die of the virus, the fatality is associated with that very profound inflammatory response. So absolutely, there's a relatively short window. We saw this in Guinea during our Ebola trial, that we had a short window of time to clear the virus, and then the subsequent sequelae didn't develop. And I would argue that it's going to be exactly the same with interferon or remdesivir or whatever antiviral you use. Once a patient is in the ICU with severe organ dysfunction and lung pathology, I don't know what the effect of clearing the virus is going to be. The advantage with interferon is it is immunomodulatory, so there may be some advantage in the context of limiting the inflammatory response, but perhaps the route there would be to go for direct anti-inflammatories.
I see. Another question is, can you elaborate on the differences of nebulized versus subcutaneous interferon alpha?
Right, so that's a very good point. So in our study, the system for inhaling was really not a great system. We moved to a different device. I suspect a lot of the interferon that we used, and it was 10 million units a day, which is a hefty dose, a fair amount of it was ingested and didn't get to the lungs. But despite that, we saw some efficacy. There are now devices that we're looking at that are actually going to deliver 100% of drug deep into the lungs. And I think since they're the first target of virus infection, that would be a very effective strategy to be seen in the RCT when we compare with sub-Q. That's my answer to that question.
Thank you. So there is a question that I see here from coming. One second, I think this is actually from Kurt Horvath. Oh, no, here's another question. So I have a final philosophical question for you. And it comes down, you have seen other epidemics. You've seen the SARS, the regular SARS epidemic, Ebola. What do you think is going to happen in the world? I mean, what's if you, I mean, I know you said you're not a prophet, but the way this pandemic is evolving, what can you make some predictions of from what you've seen before in other epidemics?
Well, I'm watching a lot what other far more smart and intelligent folks are saying, and it seems to me that the response to this pandemic far outstrips the severity of the disease. One of the problems was that we didn't have in place rapid responses, that the warnings were not adhered to, and governments failed to respond rapidly. And that's why it got out into the community. With SARS coronavirus 1 in Canada, it never got into the community, and we never had this kind of infectious rate. So that's the first thing, that hopefully for the next pandemic, and there will be another pandemic, the response rate will be far more rapid. But I also think a major issue here is that the economic impact, and I know we're not economists here, the economic impact far outweighs the response of shutting down the economy has had a dramatic effect and will persist for a number of years. So I think we need to have a measured, rapid response to a pandemic. We need to be absolutely sure that we have the testing and the contact tracing in place. And this will require a global cooperation. Let's see.
Okay, great. Okay, well, thank you so much for a great presentation, and thank everyone for being here today. We'll see you next Friday. Thank you. Bye-bye.